this is one of the very, very important topic in our clinical medicine, the fatty liver. Okay, in fact, this is the most common diagnosis whenever you send a patient for the ultrasound examination. So most of the times, while working up for your transaminases elevation, you will get the answer as a fatty liver. And sometimes as a routine investigation of your ultrasound abdomen for other reasons, for other indications, again, the co-diagnosis is the fatty liver. In fact, this is the most common chronic liver disease in the world right now. Okay, so with this background, we will move on to the topic proper. So this is the healthy liver and the fatty liver. See the difference between the healthy liver and the fatty liver. See, to call it as a fatty liver, there should be more than the 5 to 10% more of the fat in the hepatic cells. So it can be considered as a steatosis, and then there will be the steatohepatitis, and there will be the inflammation, the fibrosis, cirrhosis, and finally hepatocellular carcinoma. See, 5 to 10% of the fat in the liver can be a bit dangerous also. So that is the fatty liver. You are very much interested in this fatty liver is transformation to the cirrhosis, transformation in the hepatocellular carcinoma. So it is a common but also a reversible condition as long as it is in the steatosis condition. Once it enters into the steatohepatitis or NASH, and it is not a reversible one, it is a progressive one. So we are very much interested to diagnose the fatty liver at the stage of the steatosis alone, so that with your lifestyle measures and with your physical activity and abstinence from the alcohol, etc., so you can convert back to the normal liver with these things. It may not have any symptoms. Mostly it is an asymptomatic condition and doesn't cause any of the permanent damage in most of the individuals in fatty liver. So there are the certain risk factors for the fatty liver. Obesity, overweight and obesity is the one. So diabetes, hypertension, dyslipidemia, etc. So the root cause here is the insulin resistance. Okay. So malnutrition also may prone for the fatty liver. And of course, excess alcohol use, more than 20 grams a day. So 20 grams a day is about 60 ml of the whiskey and about the 200 ml of the wine or the 500 ml of the beer. So that is about the 20 grams of the alcohol per day. There will be the high cholesterol and the high triglyceride levels. That is a part and parcel of your dyslipidemia when the cholesterol is more than the 200 and the triglyceride is more than the 150. So there will be the more and more lipotoxicity and accumulation of these fat cells, fat in the hepatocytes, and leads to the fatty liver. Taking excessive dose of the certain medicines, so especially your steroid therapy, your amiodarone, your methotrexate, see the immunosuppressive drugs. So these are all the drugs which can cause or which can potentiate the person to go into the fatty liver. So most common drugs are the steroids. And of course, it's a part and parcel of the metabolic syndrome. You know the 4 subtypes of the metabolic syndrome, ingredients of the metabolic syndrome as diabetes, hypertension, dyslipidemia, and obesity. And the 5th one is the fatty liver. So the fatty liver is also an extension of the metabolic syndrome. And the root cause of the metabolic syndrome is the insulin resistance. The same insulin resistance is also a reason for the fatty liver. So some genetic inheritance. So the fatty liver runs in the families also. Too much of the iron in the body, that is hemorrhoids, or the Wilson's disease, or Hep B, or Hep C. So these are the other reasons to cause the more and more fatty liver in our society. The 2 main types of the fatty liver are the alcoholic liver disease and non-alcoholic liver diseases. See, this alcoholic liver disease is very, very common in our society. Nowadays, now we are seeing a lot of the hepatitis, alcohol-induced hepatitis and alcoholic gastritis, alcoholic pancreatitis, see, alcoholic encephalopathy. So these are very much related. It's a very almost, it will affect each and every organ in the body, and they're more prone for head injuries, more prone for the fractures, etc. And non-alcoholic fatty liver disease, the cause of this fatty liver is not known. See, non-alcoholic fatty liver disease or the fatty liver is an exclusion diagnosis. So you have to exclude the alcoholism, you have to exclude the certain causes of the fatty liver like your extrahepatic steatosis, etc. So then only you can consider it as a fatty liver, non-alcoholic fatty liver disease. And I also told you how much amount of the alcohol one has to consume to cause the alcoholic hepatitis. So most of this condition is asymptomatic, but still some people, they may present with loss of appetite, maybe the nausea, vomiting, yellowish of the skin, that is the jaundice, abdominal pain, especially the right abdominal pain, and acute fatty liver of the pregnancy. See, the acute fatty liver is the rare condition of the pregnancy which can be life-threatening. Symptoms begins in the third trimester in the fatty liver in the pregnancy, which may include the persistent nausea and vomiting, general malaise and the pain in the right upper abdomen, and presence of the jaundice. See, not only the weight loss and the abdominal pain, asthenia, tiredness, see, nausea, confusion, poor judgment, or the trouble consent. So these are also the other symptomatology of the fatty liver. So the diagnosis of the fatty liver is by two means. One is the imagology and the second one is the biopsy. And imagology is very easy to diagnose the fatty liver, whether your ultrasound or your fibroscan or your CT or your MRI, etc. And the liver biopsy is the gold standard, but most of the times we don't do the biopsy to diagnose the fatty liver because of its invasive procedure. A needle will be inserted into the liver and the tissue will be taken out for the certain test as the biopsy. So this is about the diagnosis of the fatty liver. The treatment, there is no certain treatment of the fatty liver. Mostly the risk factors elimination and mostly the lifestyle measures, good exercise activity and reduced saturated fats and no trans fats, more fiber, more fruits. So these are the very, very important. And if they are overweight or the obese, so definitely the 5 to 10% of the weight loss will definitely give you a lot of the benefits. Alcohol quitting is very, very important, and managing the cholesterol and the sugar levels with the appropriate drugs, and eating healthy and the balanced diet can help to reduce the fatty liver. What about the nutrition? See, this is the very good chart. Show you the epidemiology, diagnostic challenges, predictors of the disease progression, the causes of the death, and the role of the liver transplantation also. See here, the fatty liver, don't think that fatty liver is related with the liver alone. So the more the fatty liver people, they will have more and more atherosclerosis. The fatty liver will predispose to a cause of ischemic heart disease. Fatty liver people more prone for the non-hepatic malignancies. The fatty liver people are more prone for the CKD, more prone for obstructive sleep apnea. So these are the diseases which are very, very common in our internal medicine practice. So a lot of these diseases are related to the fatty liver. So now the fatty liver is no more a disease of the liver, but also the disease of the other systems. Okay. See the global prevalence. It's a very, very common in Middle East, Asia, South America, and least common in Africa. So maybe because of the urbanization, globalization, and then economization. So this is a very, very common in both the developing and the developed countries. Predictors of the disease progression, you will have already told you the type 2 diabetes, metabolic syndrome, obesity, hypertension, some genetic disorders. And it is common in both the males and the females, and more common in the males. It is also common in the postmenopausal women. Yes, see, nowadays now we are seeing the fatty livers even at the age of the 15 years, 16 years, or 20 years also, maybe because of the childhood obesity and the no physical activity in the school going children. And now another important predisposing factor, the dysbiosis of the gut. See, earlier we thought that there was only the two-hit hypothesis as far as the fatty liver is concerned. And one hit is the accumulation of the fat in the hepatocytes, and the second hit is an occurrence of the inflammation or the fibrosis or the nodule formation. Nowadays, it is not the two-hit hypothesis, but it is multi-hit hypothesis in fatty liver. So what you mean by multi-hit hypothesis? It's a complex interplay between insulin resistance, your lipotoxicity, and your pro-cytokines releases like your adiponectokines or tumor necrosis factor and interleukins, etc. And dysbiosis of the gut and then oxidative stress. See some disturbances in the immune system. So these are all the factors now related to cause the fatty liver. So no more it's only the lipotoxicity, but also your lipotoxicity and your oxidative stress, your dysbiosis of the gut, okay, and the cytokines, inflammatory cytokine accumulations. So these are insulin resistance. So these are the important hypotheses pertaining to your fatty liver. See the liver transplantation. See earlier the most common reason to get the liver transplantation is maybe your hepatitis C or hepatitis B or hepatocellular carcinomas, etc. Now the most common indication to go for the liver transplantation is the fatty liver with an inflammation, with the fibrosis, with the cirrhosis, so etc. So with this background, you agree with me that fatty liver is a very, very common disease. The most common metabolic liver disease, a chronic liver disease in the world. Very, very common in our India because of the more cases of the type 2 diabetes. So the reason to get that fatty liver is again insulin resistance, because it is an extension of the metabolic syndrome, and left untreated, most of these people will go into the cirrhosis and hepatocellular carcinoma, and it could be an important reason to get for the liver transplantation also. And fatty liver people are more prone for the ischemic heart disease, more prone for CKD, and more prone for the other diseases also. So this is a very, very important disease, and every physician should be aware of these conditions of the fatty liver. What are all the risk factors for the fatty liver? What is the multi-hit hypothesis? And what about the left untreated? What are all the complications? And then you act accordingly. See, this is the prevalence of the NASH. That is the in India about 5 to 28%. I think more than the 28%, maybe 38 to 48% is very, very common in Indian population. See, hospitals studied with the NASH-related cirrhosis and the complications right away. So even most of the hospitals in the US and in the Europe, so a lot of the people, they are in the gastroenterology departments with the NASH and the cirrhosis. So the same thing will also happen in India in the next, say after 1 decade or the 2 decades. And definitely every hospital should have at least 100 to 200 bedded gastroenterology department, exclusively hepatology and exclusively for the services of the fatty liver and its complications. So that is the magnitude of the problem of the NASH in India right now. It is the most emerging cause of the chronic liver disease, projected to surpass the leading indication of the hepatitis C for the liver transplantation. And non-alcoholic fatty liver and NASH progress to the cirrhosis in 2 to 3% and 15 to 20% over the 10 to 20 years time. See, even the 2 to 3% in Indian population, so the number of the cirrhotics converting, getting from the fatty liver are enormous, are a very huge number of the cirrhotics are there in India. See, there is a study done at Kakinada, screening of the school children, about 752 people in the private schools, a little bit high socioeconomic, and about 326 students from the government schools with a low socioeconomic strata. See, the obesity is about 8.24%. See, if you see that today, definitely this obesity, the children may be 12 to 14% of the 15%. 17 by 62 are the hypertensives. See, 24% hypertension, even the school-going children. Physical activity, less than 4 hours per week. Per week, less than the 4 hours physical activity. Junk food consumption, more than 2 times per week. Maybe this week, maybe 5 times a week or 7 by 7. Okay, so 90% of the children, both the children studied in the private schools as well as the government schools. So 90% they are the junk food consumption fellows, and watching TV more than the 4 hours. See, imagine these children when they grow old. So definitely all of these children are prone for metabolic syndrome, prone for diabetes, hypertension, and also your extension of the metabolic syndrome, fatty liver. So we have to catch up these people in an younger age group. So encourage them for the more physical activity, encourage them from not to have the junk foods, encourage them to take more and more fruits, and then the fiber. Okay, so the complex carbohydrates and less saturated fats, no trans fats, more protein. So these are the very, very important habits one should cultivate even from the childhood itself. Otherwise, so India is going to face a lot of big problem as far as the health is concerned. A lot of these people will convert to metabolic syndrome. So I give you one index case. A 49-year-old executive had a routine health checkup. BMI 31, so obese, and also had an abdominal adiposity, abdominal obesity, and blood pressure hypertensive. When the systolic is 40, 140 or more than 140, diastolic 90 or more than 90 is hypertensive. And diet, home food. However, the frequent intake of the burgers, cola drinks, and the desserts. Okay. No to very rare intake of the alcohol. So this is the index case. So it shows that a 49-year-old executive, okay, obese, hypertensive, and eating lot of the junk foods and the cola drinks, Coca-Cola, etc. Now the bilirubin is 0.6, a normal. ALT and AST are elevated. See 30, 62 and 38. Okay. So your normal should be around 30. Cholesterol 290. Your normal is less than 200. LDL 180. So your normal must be less than 70. No more 100, even less than 70, maybe 55, maybe 35. Okay. So if not, at least 70 is our ideal LDL nowadays. Triglycerides 270. Okay. HDL 36. It should be more than 40. Fasting blood sugar 130. So that means a diabetic. Fasting more than 126 and more than is definitely a diabetes. Postprandial 180. Impaired glucose tolerance. HbA1c is negative. Hep C negative. ANA negative. Iron studies are the normal. Ferritin 2 times elevated to the upper normal limits. And ultrasound abdomen fatty liver. So in other words, it's a case of metabolic syndrome. So you have the obesity. You have the hypertension. You have the fasting blood sugar more than 126, that is 130. And then you have the dyslipidemia. So elevated triglycerides, low HDL, elevated LDL, elevated cholesterol, and the fatty liver also there in your ultrasound examination. So what is the treatment here? So whatever amount of your metformin or your dapagliflozin or the sitagliptin or your ACE inhibitors, ARBs, they are not of much use unless you advise very, very good dietary approach and the exercise. So lifestyle measures. So the lifestyle measures are very, very important for here. So with the lifestyle measures, you can reduce the fasting blood sugar to 100, postprandial to 140, your blood pressure to 120/80, and you can reduce the body weight. So the abdominal adiposity has gone, and then you can reduce the BMI from 31 to maybe 24 or 23. So all are possible, not with the drugs, only with your dietary approach and exercise. And obviously, the fatty liver also will disappear, provided if it is not in the stage of the NASH. If it is only steatosis, so definitely that is a reversible condition. Once it enters into the NASH, and it will be a progressive, even with your dietary approach and your good exercise program, even the progression is also much delayed. So you can stop the further progression, and you can delay the onset of the cirrhosis or the other complications very slowly. So that is the aim. So as a physician, so you should know all the ingredients of this case, and finally the final conclusion of your diagnosis, and ultimately what could be the correct treatment for this fellow. So here I don't think that pharmacotherapy is the answer, but non-pharmacological management is the most important answer for them. So the lifestyle methods are very, very important. Okay, am I clear? Fine. Should he be worried about the fatty liver? Yes. In this person is a malnourished, is not malnourished, is overnourished. Fatty liver, non-alcoholic fatty liver disease, NASH, and the cirrhosis. So this is here. See the simple steatosis, the first picture. So that will be then to the steatohepatitis, that is a NASH. So this is because of the gut microbiota, adipose tissue inflammation. So your fatty cells inflammation, and there will be the lipotoxicity, there will be the lipolysis, and there will be the free fatty acid conversions, and then more and more VLDL, and more triglycerides. So this is all hangama will take place in the hepatocytes in the liver to cause adipose tissue inflammation. And when the patient is having more and more hyperglycemia, etc., there will be oxidative stress and hepatocyte apoptosis, that is the programmed cell death, and there will be the inflammation in the hepatocells, finally leads to the NASH. From this stage, it is not a reversible one. It is an irreversible and a progressive one, and leads to the fibrosis, and then the nodular formation, so then the cirrhosis, and then finally other things. See the NAFLD, that means more than 5% fat content in the liver. So less than 5% is the ideal one. Once it is the more than the 5% of the fat content in the liver, so it leads to the fatty liver. So the WHO definition of the malnutrition. Malnutrition refers to deficiencies and also excesses or imbalances in a person's intake of the energy and other nutrients. Okay. So the term malnutrition covers two broad groups of the conditions: undernutrition or the overweight and the obesity. Both are malnutrition. So don't think that malnutrition means undernutrition. Mal means disturbed. So disturbed nutrition. Lower is the undernutrition, higher is the overweight and the obesity. So a multi-nutrition refers to the deficiencies, excesses and imbalances. So you know the undernutrition, that means stunting, low height for age, wasting, low weight for the height, underweight, low weight for the age, and micronutrient deficiencies or insufficiencies, a lack of the important vitamins and the minerals. See, unfortunately, still a lot of the people are undernutrition in our country. Okay. Then the overweight and the obesity, and the diet-related non-communicable diseases such as the NAFLD, cardiac problems, CVS, diabetes, malignancies. So these are very, very common associated with the overweight and the obesity. Obesity will cause all these diseases, including the malignancies also. So your breast malignancy, endometrial malignancy, gut malignancy. Okay, so these are very common in our obese individuals. So the nutritional deficiencies in the liver disease. There will be the impaired digestion, insulin resistance, there will be the nausea, ascites, a feeling of satiety and the bloating. SIBO, what is SIBO? Small intestinal bacterial overgrowth. Okay, yes. Then the impaired biliary excretion, impaired absorption, loss of appetite, and inadequate intake. So these are all the nutritional deficiencies in the liver diseases. Established and suspected risk factors for the non-alcoholic fatty liver disease. See, established risk factors are metabolic syndrome, your obesity, diabetes, hypertriglyceridemia, metabolic syndrome. Suspected risk factors: hypothyroidism, hypopituitarism, hypogonadism, obstructive sleep apnea, PCOD, total parenteral nutrition, excess fructose consumption, okay, rapid weight loss, and then the genes which are related in the gene, those runs in the families. So these genes, PNP, LA3 and TM6SF2 genes. So genetical predisposition. So some people who are genetically predisposed to these genes, when the environmental factors are there, like your overweight and etc., so they are more prone for the fatty liver. So you have the established risk factors and the suspected risk factors. And among these suspected risk factors, we have many suspected risk factors in our Indians. So starting from your hypothyroidism, obstructive sleep apnea, PCOD, and then excess fructose consumption, so rapid weight loss. So these are all risk factors to have the non-alcoholic fatty liver disease. See the natural history. If you see the non-alcoholic fatty liver disease, to convert into the hepatocellular carcinoma, the advanced fibrosis or the cirrhosis, it takes very long period. Not 1 month or 2 months or 2 years or 3 years, maybe 5 years, 10 years, 15 years, 20 years, etc. See, we have to see this. Those people who are infected with, who are diagnosed with the fatty liver, so much more concentration has to be given on the diet and the exercise. And of course, if the patient is very severely diabetic, so definitely have to treat the drugs to reach your euglycemia. In the same way, hypertension has to be treated, dyslipidemia has to be treated, but there are no particular drugs which act on the fatty liver. So we say that vitamin E will work here, pioglitazone will work here, saroglitazone will work here, but there are very few drugs are there in our hand. Right now, the best treatment for the treatment of the fatty liver is only your diet and exercise. See the energy intake and the energy expenditure. So the obesity. So the more the energy intake and less the energy expenditure, obesity will lead to the non-alcoholic fatty liver disease. So high fat diet, high fructose diet is obesity, and then gut microbiota, gut barrier integrity, metabolic endotoxemia, low grade inflammation. So these will lead to the fatty liver compositions. See, unfortunately, most of the diets right now, they are high calorie diets and high fatty diets and high fructose diets. This represents a spectrum of the diseases involving the hepatic fat accumulation, inflammation with the potential progression to the fibrosis and cirrhosis over the time. Often associated with obesity, IR, and diabetes, the gut-liver axis plays a crucial role in the non-alcoholic fatty liver disease onset and the progression. Now, this concept of the dysbiosis of the gut is very much needed to cause the fatty liver. So, gut-liver axis plays a critical role in the non-alcoholic fatty liver disease. Impact of the current diet on the non-alcoholic fatty liver disease. They have shown high energy intake, significantly lower protein and the carbohydrate intake. Unfortunately, most of our Indian diets, they are not containing much protein. They are containing high calories, high fats. Okay, so higher total fat, higher intake of the saturated fat, and omega-6 consumptions. So these are all very much related to cause the insulin resistance. And once the fellow is having the insulin resistance, so definitely these people will have lipotoxicity, will have the glucose toxicity, and they have the more and more lipolysis and free fatty acid consumption. So definitely will lead to the fatty liver by oxidative stress, apoptosis, hepatic inflammation, and fibrosis. See how the saturated fatty acids will lead. What are the foods rich with the saturated fatty acids? What are the red meat? What are the refined grains and high fatty diet? Western type dietary patterns, highly processed foods, sweets, candies, sugar sweetened beverages. So they are all responsible for the fatty liver. So the dietary pattern in non-alcoholic fatty liver disease patients may bring changes in the intestinal barrier function. So this is all the global prevalence. I told you India is no exemption. So it is everywhere in all over the world. In particular, role of the macronutrients in the progression of the non-alcoholic fatty liver disease. See, it is a multi-system, metabolically driven, inflammatory disease, affecting the several target organs. I told you not only the liver, but not limited to the liver alone. So both macro and micronutrient abnormalities play a role during the progression of the non-alcoholic fatty liver disease. Low levels of the folic acid and the vitamin B12 are significantly related to the severity of the NASH. So our diet should contain equal amounts of the folic acid and the vitamin B12. So the deficiency of the folic acid and the vitamin B12 are significantly related to the NASH. What about the effect of the high carbohydrate intake? High carbohydrate intake and the fructose intake upregulates the transport of the fructose through the GLUT5 transporters. They increasing the endotoxin release, epithelial dysfunction, and reduction of the tight junctional proteins. So that leads to the inflammation and non-alcoholic fatty liver disease progression. So the fructose is the one that is most related to the progression of the non-alcoholic fatty liver disease. Then the micronutrient deficiencies. Okay, so the dietary patterns markedly impact the development and progression of the non-alcoholic fatty liver disease. So the fruits rich with the fructose, mangoes. Okay, dietary patterns must be addressed with the therapeutic interventions. Adherence to diet is critical for the long-term success. So always, so definitely the adherence to the diet is very, very important for the long-term success. Diet recommendations in the NAFLD to prevent the progression Lifestyle recommendations. Hypocalorie diet. So diet reduction by 500 to 1000 kilocalories a day. Women should eat 1200 kilocalories per day. Men about 1500 kilocalories per day. Low carbohydrate diet. So 40 to 45% of the total calories. Coupled with increased dietary MUFA and omega-3 polyunsaturated fatty acids and reduced saturated fatty acids. More fiber in the diet. Moderate intensity exercise to lose 7 to 10% of the total weight and sustaining the weight loss over the time. Optimal daily protein intake about 1.2 to 1.5 grams per kg. Patients with NASH may benefit from antioxidant supplementation with vitamin E, about 800 international units per day. So this is the most important slide of our today's talk. So we all know that we are seeing a lot of the fatty livers in our practice. So the answer to the fatty liver, this is the best answer. So only with the diet and exercise, and this includes a hypocaloric diet, maybe 1200 to 1500 calories, low carbohydrate, usually avoid the fructose, okay, less saturated fats, more polyunsaturated fats, more fiber, more fruits, more exercise, okay, and then the equal amount of the protein. See, the most of the Indian diets, they are protein less, protein deficient or insufficient. So definitely 1.2 to 1.5 grams per kg protein intake. And then finally, vitamin E as an antioxidant, about 800 international units per day is needed to avoid the fatty liver conditions. So this is the fibers, reduction of the liver fat, reduction of the inflammations, and vegetable provides dietary fiber and also vitamin A and the E. Phytochemicals, your folate, tocopherols, carotenoids, which have shown anti-tumor activities in the different diseases. See, PUFA administration improves the plasma lipid profile. So hepatic steatosis and the liver injury. Protein diet, okay. Particular attention must be paid to the protein intake needed to maintain the muscle mass because of the potential risk of exacerbating the sarcopenia during the weight loss intervention. Okay, see, we see a lot of the sarcopenia in the elderly individuals. So when the age is more than the 70 or 75 years, so most of the people will see the sarcopenia. So the dietary indications for non-alcoholic fatty liver disease recommended: whole grains, monounsaturated fatty acids, omega-3 polyunsaturated, more proteins, more fiber, prebiotics, resveratrol, coffee, taurine, choline. Avoided simple sugars like fructose, saturated in the trans fats, and animal protein most of the times, processed meat. So these are nutritional guidelines. So the complete nutrition include: proteins are the building blocks of the body and they are required for building the muscle mass, growth and the tissue repair, improves the immunity, sources the milk, eggs, sprouts, fish and the chicken. So they are the rich with the protein. So building the muscle mass. Vitamins and the minerals act as a catalyst for the healthy growth. They improve the eyesight because they contain vitamin A, makes bones and the teeth strong because they contain the calcium and the phosphorus and vitamin D3. They increase the hemoglobin levels. Sources of the fruits, green leafy vegetables. Carbohydrates and the fats are required to provide the energy. Fats help the absorption of the fat-soluble vitamins A, D, E, K. Fats provide the protective cushion for our organs. Fats regulate the production of the sex hormones. Sources for your carbohydrates and the fats are the rice, sugar, corn, bread and cereals, butter, oil and chicken. See, this is the prebiotic fructo-oligosaccharides. So the dietary fructans, stomach, small intestine, colon. So then the increase in the number of the beneficial bacteria. Fermentation produces and beneficial bacteria independent effects. So mechanism by which B12 fructans may influence the host defense. So complete nutrition has to be balanced. Fill your plate with the right balance of the healthy foods. Pay particular attention to the protein, calcium, and the vitamin D. If you are not able to achieve a well-balanced diet each day, WHO recommends a complete balanced oral nutrition supplement to improve the muscle mass and strength, which supports the mobility and the weight attain. So advice to the patients, virtually no food other than the alcohol actually damages the liver and are genuinely contraindicated in patients with the chronic liver disease. Try to split your food intake into 3 main meals, breakfast, lunch and dinner, and 3 snacks, mid-morning, mid-afternoon and late evening. The late evening snack is the most important as it covers the long interval between the dinner and the breakfast. Medical nutrition therapy may help the supplement the meals. So the careful nutritional support is beneficial, and by implementing a targeted practical approach in clinical settings, improvements in the patient outcomes can be seen. Weight loss by means of calorie restriction and exercise, replacing the appropriate calories with the complete and the balanced. So let us spend some more time on recent advances in the management of fatty liver. Here a 55-year-old male, a non-smoker, no history of alcohol consumption, editor by profession, presented to us with the painless hematemesis, 4 episodes from the last 4 hours. See, this is your Sirisha, your picture. Active bleed from the esophageal varices, endoscopic varical band ligation done, hemostasis is achieved. Okay. So 4 boards of the hematemesis in the last 4 hours. CT abdomen, features of the cirrhosis with no ascites or no liver SOL. Hep B and Hep C, they are the negative, non-alcoholic, non-smoker. Okay. Liver biopsy, features of the cirrhosis with steatohepatitis. So the final diagnosis, esophageal varical bleed, portal hypertension, cirrhosis, and etiology is hepatitis B and C negative, no alcoholism, no other causes except fatty liver. So such type of the cases are there in the near future in most of our Indian population, more so in our South India, more so in our Godavari districts. Okay, so because of the increased incidence of the metabolic syndrome, because of the faulty food intake, because of the high calorie diet, because of the high saturated fats. So this is very, very important. So more than 5% of the hepatocytes display the macrovesicular steatosis, that is a fatty infiltration. So that is your fatty liver. In the absence of the readily identifiable alternative causes of the steatosis. So some people say fatty liver, some people say NAFLD, some people say MAFLD. So that is metabolic dysfunction associated fatty liver. This is a new nomenclature. Okay. So MASLD, that is a more recent, that is a metabolic dysfunction associated steatotic liver disease. Accepted terminology. So the increasing the obesity, now the obesity capital of the world is India. So a lot of the people are obese. So in the adults, fatty liver or metabolic associated liver diseases, in the adults about 38.6% prevalence. In the children, 34.4%. Both in the males and the females, same, but more in the postmenopausal women. Urban 40%, rural maybe 30%. I don't think that is not of much difference in the urbanization and the ruralization. Now the ruralization, so now there is a big urbanization of the rural India. So I think both are the same in most of our population. See the prevalence of the fatty liver here, very, very high in the metros. So this pathogenesis already I told you. The major modifying factors are the genetical polymorphisms, gut microbiota, environmental factors and the social factors or physical activity, etc. and dietary saturated fat versus the polyunsaturated fatty acids. Alcohol consumption. So 1 drink or less in a day for women, 2 drinks or less in a day for the men, or the non-drinking. So this is the very, very important. You should know what about the 10 grams of the alcohol means. I think 10 grams of the alcohol means 30 ml of the whiskey, or 100 ml of the wine, or 250 ml of the beer. So that is about the 10 grams of the alcohol. So to cause the liver disease, there should be a continuous consumption of more than 20 grams of the alcohol a day. So there is no safe level of the alcohol consumption. The risk of cancer increases even with the low levels of the alcohol consumption. So it's always bad, not good for the health. Steatotic liver disease, metabolic dysfunction associated steatotic. Yes, here the alcohol associated, specific etiology, and cryptogenic. See the cardiometabolic risk here, the adult criteria here, at least 1 out of the 5. So BMI more than the 25. So in India, in the normal BMI is 23. So more than the 23 is overweight or the obese. At the weight circumference, our Indians more than the 90 centimeters in the males and more than 80 centimeters in the females is the abdominal adiposity or ethically adjusted equivalent. So the fasting serum glucose. So this is the metabolic syndrome, the features of the metabolic syndrome here. So the fatty liver spectrum, steatosis, NASH, cirrhosis, decompensated cirrhosis, and finally hepatocellular carcinoma and the death. See the risk progression. Now the causes of the death. What are the causes of the death in the cirrhotics? Maybe the cardiovascular deaths. Because I told you, fatty liver, increased incidence of ischemic heart disease, etc. And non-hepatic malignancy is also very common here. And hepatocellular carcinoma progression 1% per year. So the liver has the regenerating capacity, unlike your brain, which is not having the regenerating capacity. Here the liver transplantation, is possible. Liver, the donor, here the reduced hepatocyte, reduced liver function reserve, increase the bilirubin levels, recovered by the repopulation of the hepatocytes. So the recipient, that's how the liver enlarges and keeps the growth. So once there is a persistent injury, there is no point of no return. So that is your hepatitis or inflammations or in the fibrosis. In chronic injury, what are the causes? The viral infections, alcoholism, your NASH, autoimmune disorders, and the cholestatic disorders, and the metabolic diseases. So these are all the causes for your chronic liver diseases. And those people who are the genetically premorphisms or epigenetic markers, etc. So they will lead to the cirrhotics, etc. So this is the normal liver fibrosis and the cirrhosis. So this is the very important liver function test. So you all know that liver function test means not only bilirubin and SGPT and SGOT. So the liver function test means, as a postgraduate of the general medicine, so bilirubin, both the total and also the direct and the indirect. Okay. And then the SGPT, SGOT, or AST or ALT, and then the alkaline phosphatase, then the serum proteins, your albumin and the globulin, and PTINR. So that is the total LFT. So in all the hepatitis population and the jaundice population, you should also include that proteins as well as the PTINR as an important liver function test to be done. See the normal ALT, the males 29 to 33, in the females 19 to 25. Levels above this should be assessed. So don't think that up to 40 is the normal. Not up to 40 is the normal. Males 29 to 33 and the females 19 to 25. These are the normal values. So more than 33 in the males, more than 25 in the females. So definitely you should suspect fatty liver. Fatty liver or some injury to the hepatocytes. Okay. So this is the ACG guidelines. Males, you remember these values. Males 33 is the upper normal and females 25 is the upper normal. Asymptomatic elevated ALT by AST. 18% elevated aminotransferases. Multivariable analysis association with the ACE, hypertriglyceridemia, diabetes, and obesity. So don't rely on the lab upper limits for the LFT interpretation. So male more than 33, female more than 25. So it's a red flags. Why? What is the cause for this elevation? Once it is more than 33 in the males and more than 25 in the females. So non-invasive test for the fatty liver evaluation. So this is the very important APRI. What you mean by APRI? A stands for AST, P stands for platelets, RI is ratio index. So AST divided by platelets. So that is your APRI value. Okay. So then FIB4. So that is your A is into AST, platelet count into ALT. And then the fibrosis score. So this is the different scores are there. One thing is very important. It's very non-invasive. So you please remember the APRI score. So APRI is AST platelet ratio index. Here cutoffs is the 0.5. Gray zone 0.5 to 2. And more than 2 or more than 2 is always definitely we have to take into the consideration. So this is the APRI. And if you consider the FIB4, so less than 1.3, 1.3 to 2.67 and more than 2.67. So one should assess the reason for that. So here you should remember the APRI and if possible FIB4. So this is a transient elastography, a liver stiffness measurement, cutoffs and the vibration controlled transient elastography. Either significant fibrosis, unlikely, less than the 6, and more than the F2, more than the F3 and F4, etc. So this is the transient elastography instrument showing the fatty liver estimations. So whom to screen? See, additional causes of hepatic steatosis, they are the alcoholic, hep C, some drugs like steroids, malnutrition, total parenteral nutrition, hepto-beta lipoproteinemias, Wilson's, celiac, lysosomal acid lipase, so etc. Okay. So incidental detection of the elevated transaminases, the patients with obesity, type 2 diabetes or the metabolic syndrome, screen for the fatty liver using the ultrasound abdomen, hepatic steatosis evidence on the ultrasound, then the incidental detection of the fatty liver on the ultrasound. So these cases you should go for the APRI or the FIB4 and then AST more than the 33 or more than the 25 in the females, so etc. So what about the indications for the liver biopsy? Okay, to assess the stage of the fibrosis, we need it if the discordant and indeterminate NITs are discordant between the NITs and the clinical or imaging and the lab features. To assess the stage of the fibrosis, you need a biopsy in these individuals. To confirm the diagnosis, competing or the concomitant possible diagnosis like autoimmune hepatitis or persistent elevation in the liver chemistries. So there you may need to confirm the autoimmune hepatitis, you may need a biopsy. So what about the treatment? It's a systemic disorder, no more a disease of the liver. It's almost a systemic disorder. It involves all the systems. Need a multimodality treatment. Treatment of all individual aspects. What are all the individual aspects? Here the NASH, liver-related complications, sometimes malignancies, osteoporosis, sleep apnea, abdominal adiposity, type 2 diabetes, CVE, cardiovascular diseases, cardiac abnormalities and arrhythmias, CKD, PCOD, psoriasis. So here the psoriasis and osteoporosis. So they are also concerned with NASH. All the things already I told you. So when you are dealing a case of the fatty liver, you please think of all these things. So it is a multimodality treatment. It's a systemic disorder. So as I told you, lifestyle interventions are very important. Pharmacotherapy, very, very few drugs are available. Bariatric procedures of questionable improvement and management of the metabolic risk factors or the modifiers is very, very important. So first and the last are very, very important. Lifestyle interventions and management of the metabolic risk factors. Weight loss is a very, very important. Suppose if they lose weight loss of more than the 3% at the top, so steatosis. If the weight loss of more than the 5%, So the ballooning and inflammation reduction. In the weight loss of more than the 7%, so NASH resolution. So it's a reversible one. When the weight loss is more than the 10%, even the fibrosis also will come down by 45%. So these are all the advantages of the weight loss. At least 10% of the weight loss will reduce a lot of steatosis and the inflammation, steatohepatitis, and even the fibrosis also can be reduced to some extent, maybe up to 45% with the weight loss of the 10%. So all the obese and the overweight population with the fatty liver, so one should concentrate on the weight loss to get all these benefits. So the lot of the lifestyle interventions are there. 3 months restricted fat diets, 7 weeks on average low very fat diet, 12 months nutritional counseling. So you have the different outcomes. So the liver enzymes are reduced, etc. Insulin resistance is also reduced. So finally you got very good benefits of the fatty liver reduction. Weight loss through lifestyle modification significantly reduces the features of non-alcoholic fatty liver disease. Okay. So degree of the weight loss independently associated with improvements in all NASH related histological parameters. Diet, calorie restriction appears to be more important than the specific type of the diet. So the final at the end of the day, the calorie restriction must be there. In the males about the 1500 calories, in the females about 1200 calories. See, daily calorie restriction by 30% or 500 to 1000 calories per day to achieve the target weight loss. Total fat, already I told you. So 2 cups of caffeinated coffee per day in the non-alcoholic fatty liver disease. Indian habit of sweetening their coffee is a counterproductive. So don't add the sugar, but take 2 black coffee. Okay. Without sugar. Aerobic versus the resistant exercises in non-alcoholic fatty liver disease. See, always in exercises, resistance exercises, intensity exercise, consumptions. So both are very, very important here. Both aerobic and resistance exercise reduce the hepatic steatosis with a similar frequency, duration, and period of exercise. So exercise should encourage for all the population for 2 reasons. Not to reduce the body weight. If they reduce the body weight, well and good. Even if they don't reduce the body weight, if the people are on regular exercise program, and definitely the steatosis or the fatty liver reduction which be achieved. So moderate intensity aerobic include brisk walking, jogging, running, swimming, cycling, etc. So what about the pharmacotherapy for the NASH? Okay, vitamin E and pioglitazone. See, vitamin E already told you 800 international units, and you all know that the pioglitazone is a thiazolidinedione, which acts at the level of the liver to reduce the insulin resistance at the level of the liver, muscle, and adipose tissue. See, this has a counterproductive. See, the common side effect of the pioglitazone is weight gain. The common side effect of the pioglitazone is edema of the body, weight gain, anemia, osteoporosis in the postmenopausal women, and urinary bladder carcinoma in males. So these are all the few side effects of the pioglitazone, but you have to see risk versus the gain, and definitely the pioglitazone can help in reducing the fatty liver, but you have to assess the side effects of the pioglitazone also. Improvement in the fibrosis, because this pioglitazone here the dual PPAR agonists like the saroglitazone. So this acts both on the PPAR alpha and the PPAR gamma receptors. So one is related with the hyperglycemia, the second one is related with the hypertriglyceridemia. So in a people with both hyperglycemia and hypertriglyceridemia, so you can use this molecule saroglitazone, the Indian made drug. So this will help you the things. See, we have the PPR gamma, the drug is a pioglitazone, and PPR alpha, your hypertriglyceridemia, you have the fibrates. So if you combine both these, you will have a saroglitazone, which will act both on the hyperglycemia as well as hypertriglyceridemia. This saroglitazone will work in fatty liver, so reduces the fatty liver. See, the saroglitazone is a novel dual PPAR alpha and gamma agonist for NASH. See, vitamin E and the pioglitazone. Use of these agents should be personalized for the selected patients with histologically confirmed the NASH after careful consideration of the risk versus the benefit ratio, because you have the few side effects with the pioglitazone. Now the liraglutide. So what is this liraglutide? GLP-1 receptor agonist. Okay. So GLP functions in the peripheral tissues. You know how the GLP-1 act. So GLP-1 act on the alpha cells, will act on the beta cells of the pancreas. They act on the intestines. They act at the level of the muscle adipose tissue also. And to some extent, they also act on the brain satiety center. So this liraglutide safety and efficacy in patients with non-alcoholic steatohepatitis. Now the semaglutide. So this is another drug, obeticholic acid, to multiple key pathways in the animal models for the treatment of the NASH. Failed to show the direct benefit in the NASH is your statins. So don't think that statins will act to reduce the fatty liver. So there is no clear-cut evidence to say that statins will reduce the fatty liver. So the metformin, the same, the metformin. So these two drugs we often use in our diabetic individuals. So the metformin and the statins. Surgical interventions for the weight loss, your bariatric surgery, endoscopic bariatric surgery. These are the modifiers of non-alcoholic fatty liver disease. Comorbidities like obesity, metabolic syndrome, insulin resistance, type 2 dyslipidemia, hypertension, obstructive sleep apnea, PCOD, hyperpituitarism, low growth hormone, hypogonadism, hypothyroidism, okay, iron overload, hemochromatosis, Wilson's disease, psoriasis, osteoporosis. So these are the genetical markers. So genetically predisposed. Microbiome of products, nutrition and the behavior. So these are the very important for our Indian population. So a lot of the people are alcoholic, more of dyslipidemia, more takes the fructose, that is the simple sugars, and very little physical activity and coffee. Okay, so this is the very important. So the precancerous conditions of the liver cancer, precancerous conditions of the liver cancer, cirrhosis, non-cirrhotic chronic hepatitis B, and non-cirrhotic fatty liver with advanced fibrosis. So today we discussed about this non-cirrhotic fatty liver with advanced fibrosis as one of the precancerous conditions of the liver cancer. So surveillance with ultrasound liver plus serum AFT, that is alpha fetoprotein, every 6 months in all the cirrhotic cases can detect the hepatocellular carcinoma much early. So when you are suspecting the HCC, at least once in 6 months, so your ultrasound abdomen and AFT levels. So when there is a continuous elevation of the AFT levels in a chronic alcoholics or in non-alcoholics with fatty liver disease, so definitely you should suspect the hepatocellular carcinomas, etc. So this is our NASH Day, International NASH Day on June 8th. So this year's theme is the be vigilant, do regular liver checkup. Fatty liver can affect anyone. Anyone can affect anyone. So to all of us it can affect. So be vigilant, do regular liver checkup. So good dietary restrictions, good physical activity, so cessation of the smoking, cessation of the alcoholism. So definitely help us not to have the fatty liver. So thank you very much for your patient hearing.